Okay, so now we're going to talk about decelerations. This is when the fetal heart rate dips. And we would think initially that that's never a good thing. But there are some types that are really problematic, and there are some types that are not. And then there's kind of the in between. So we're going to talk about a way actually to categorize fetal heart rate strips using all of these criteria in the next section. But in this section, you're going to learn how to identify different fetal heart rate decelerations. Deceleration is when the heart rate decreases. The first kind I want to look at is an early deceleration. And an early deceleration, there's a gradual decrease in the fetal heart rate and a gradual return to the baseline, and that mirrors the contraction. So contraction goes up, heart rate goes down, contraction goes down, heart rate goes up. It begins with the contraction and it recovers with the contraction. Usually that indicates fetal head compression. It's a vagal response because the head's getting smushed. So what would that tell us? A lot of times if we haven't been seeing early decels and we start seeing them, we probably need to see if that patient has had an descent, if the fetus has moved lower. So it can often indicate progress in labor, especially in descent. It's otherwise considered a benign finding. Now, I've seen some early decels that get pretty low and you kind of get a little bit nervous, but typically these are shallower and they're just kind of a bowl shape that mirrors the contraction. So let's see what that looks like. And again, early decels are an indicator that labor is probably progressing. Let me take this down a tiny bit. All right. So this is how we know it's an early decel. We look at when that decel is completely recovered to baseline. So right here, we have a fetal heart rate baseline of about 155 with moderate variability. It's varying between 150 and 160, okay? I don't see accels in this strip. There may be some. This strip doesn't look bad. I just don't see any accels in this really short strip. But we have some early decels. This decel starts as the contraction starts. It ends as the contraction ends. So if you're not sure if a decel is early or late, and we're going to look at lates in a minute, you look at where that's recovered to baseline and you draw a line down. And if it's past the contraction, it's late. This one is recovering with the contraction. Okay. So we've got three early decels. They actually seem to mirror the strength of the contraction. They seem to be deeper with harder contractions, which sometimes we see, not always, but sometimes we'll see it really does look like a mirror. So this is early deceleration, and it's considered a benign finding that can be a sign of progress. So now we're going to look at late deceleration. But first, I want to talk to you about what we think is the physiology behind late deceleration. Remember that lake below the placenta where maternal blood goes in. The placenta has the little chorionic villi projecting down into it where gas exchange and nutrient exchange and waste occur, right? Okay. So if we're not getting enough oxygenated blood into that lake for any reason, during the contraction, normally there's enough blood remaining there to keep oxygenating the fetus. But during the contraction, when the contractions get hard enough to stop the blood flow temporarily, if there's not enough oxygenated blood, or the blood that's there's not oxygenated well enough, sitting in that space for the placenta to exchange gases, then we can see changes in the fetal heart. So what we would see at the beginning of the contraction, the fetus is okay, but then the contraction goes on, there's no oxygenated blood or they run out, and the heart rate drops a bit. And then when the contraction relaxes and we get oxygenated blood back into that space, the placenta is able to get oxygen again, then it takes just a little bit for the fetus to get enough oxygen back to recover. Okay, so that's a late decel. They usually begin after the contraction begins. They always recover after the contraction ends. It indicates inadequate oxygenation to the fetus, and that's usually because the placenta is not getting enough oxygen, uteroplacental insufficiency. That may be acute. If the mom is laying on their back, smushing the vena cava, trapping all the blood in their lower body, blood's not getting back to be circulated to the placenta, we actually can see late decels. If the mom has an epidural placed and her blood pressure drops, we don't perfuse the placenta adequately, we can see late decels. Probably the most interesting case I ever saw was we started an IV and the mom didn't say a thing. We noticed late decels. We did a quick set of vitals on the mom because she looked like she was about to pass out, and she had a vagal response to the needle. Just starting the IV made her pass out, heart rate slow, her heart rate slowed, her blood pressure dropped. That decreases perfusion to the placenta. So we saw it first in the fetal heart rate tracing because she had not mentioned feeling ill and we were looking at the IV. So as soon as her blood pressure and pulse returned, the late decels went away. So that can be an acute thing, okay? It can also happen if the mom is having contractions that are just too close together and too long to allow for recovery between them. So we see that sometimes with meds that are used for induction of labor. So sometimes that can be an acute thing. If there's not a problem with the placenta and the uterine blood flow itself, if we temporarily decrease it, we can see that. But it can also be a chronic thing, which we might see in a patient with preeclampsia or a patient with a placenta that aged early due to diabetes or post-dates pregnancy. Later in or after the due date, basically, to after if a pregnancy goes beyond 40 weeks, we see the placenta aging more rapidly, and that calcified placenta is less able to exchange gases for the fetus. We also see that happen earlier in moms with diabetes. So if the patient has diabetes, then the placenta tends to age earlier, so it exchanges gases less effectively. So we might see late decels because the placenta is just giving out, or because the mother cannot circulate blood to the placental bed effectively because of a disease process. So what do we do when we see late decels? First, let's look at how to identify them. Let's go back and go to this one. Okay, let's look at some late decels. So when we look at the contraction, you see these decels look very similar to the earlies. But if we go to where that decel ends and draw a line, that contraction ended over here and the heart rate was still down. So another way to do this, end of the contraction, go straight up, has the decel recovered. And we can see for each of these, it's recovering after the contraction. And it's starting like in the middle of the contraction. If you look at where it's starting, it's not starting at the beginning. That's not always the case, but if the contraction ends and the deceleration hasn't recovered, end of contraction, decel still down. That's a late decel, okay? Now, let's look at the baseline. This fetal heart rate baseline is about 130. With probably minimal variability with some late decels noted, okay? We can see here, there's like a little tiny accel after that decel that's called shouldering. I don't see a lot of it, but that's an overshoot when they're trying to recover, and that happens sometimes. Shouldering can indicate that the fetus is getting tired. So this is what late decels look like. Now I'm going to show you, that was late decels with minimal variability. I'm going to show you late decels with no variability, so you can get an idea of what we're looking at there. We've got to be able to see those. So you can get an idea of what that would look like. These are late decels, and there's absent variability. I would say the fetal heart rate baseline is 160. With late decels, again, how do we know they're late? In end of the decel, here's where we are. Okay. Contractions bent over. These are recovering after the contraction with no variability. We're going to come back to this strip when we talk about how to categorize strips. Okay, so that's a late decel, and that usually happens because of placental insufficiency. We're not getting enough oxygenated blood to that fetus. Now we're going to talk about variable decels, and a variable decel is usually a sudden drop. It drops much lower, and then it usually recovers very suddenly also. They can occur with contractions, but they can just happen randomly between contractions. They usually indicate that the cord is being compressed. So let's find that variable decel. Sharp drop, recovery. Okay, sharp drop, recovery. And these variables are happening with every contraction. They usually indicate the cord is being compressed. If the recovery is quick and they recover completely, which these do, and the fetal heart rate baseline and variability remain reassuring, then variable decels can be tolerated. Something that also we are going to look at is to know how concerning these are, is how close this patient is to delivery. Okay. So if we're seeing, let's look at the whole strip. We've got fetal heart rate baseline 140 with minimal variability. There are some accels noted, but only really as shoulders to these variable decels. So we have variable decels to a nadir of 80. They can get much, much lower. I've seen them go nearly down to 0, which is generally concerning. But 280 is not terrible with shouldering noted. And I would also note rapid recovery to baseline. So we have a couple of things that are concerning, but we also have some things that are reassuring. They recover rapidly. But when we look at these contractions, I would wonder what this patient's exam is, because these contractions appear to be pretty high and even squaring off at the top, meaning that they're going past the ability of the meter to read that. That may be because they have an external monitor on, and they could still be 2 centimeters and contractions look like this on the external monitor. But they're fairly close together also and lasting a decently long time. So I would want to know how close this patient is to delivery. Because if this patient is 2 centimeters, I'm not really thrilled, not so much with the variability, more with the decel, but more with the variability in between. So I'm going to keep an eye on that. If this patient is 8 or 9 centimeters, I'm keeping an eye on this, but I know that they're more likely to deliver before this gets worse. Okay, so we kind of put all of those pieces in. There is an actual structured way to categorize them, and we're going to do that in just a minute. So I want to show another strip that has mild and severe variables. Okay, and these tend to happen with the contraction, but not necessarily come back immediately. So this is a mild variable with this contraction. It's down to, looks like the baseline's 150, this variable's down to 120. Okay, it is a 30 beat drop, but it's still well within even the normal baseline range, and it recovers quickly. We also see moderate variability there. So yes, sorry, I was trying to read that. I think that's a 180 there. This should be 150. So we have a baseline of 150 with moderate variability. We've got a variable decel to 120 with quick recovery. And then we have a variable decel down to 50 that lasts a couple of minutes. When it recovers quickly. And it looks like the variability is still pretty good. Okay. I would like to see more of the strip past this. Now, sometimes if you're having a lot of these variable decels, you'll see the variability start to decrease because the fetus is getting tired, and that's something else that we watch. But this is a mild variable. This is a severe variable decel. This is still not rush to C-section. This is, I'm in the room trying to get this to recover. When it recovers, I'm probably going to let that provider know about it. Okay. Most labors have some variable decels because at some point you're going to get the cord compressed somewhere. Especially near the end of the first stage, so near the end of dilation, and in the second stage. It's very common to see deep variable decels during pushing. Very common to see deep variable decels during pushing, and those we're monitoring the progress of that pushing. We also want to know how much it comes up. Does it recover in between those contractions? That's going to be due to cord compression sometimes, but also due to that sustained head compression. If they are too frequent, they're happening too much, they're too deep, or they last too long, the fetus starts to have difficulty compensating. So you'll notice that the variability decreases. Sometimes the baseline gets higher, and sometimes you may actually start seeing some of those decels recover late. If you're seeing variable decels that are taking until, with every contraction, they're taking till a bit after the contraction to recover, we actually would call that a late variable because it's showing the fetus is struggling to recover from those contractions. What are some interventions? And I didn't talk about interventions with lates, but they're very similar. So interventions for late decel, we want to maximize blood flow to the uterus. So we're going to turn them on their left side, preferably. If we have an identified cause, we want to treat it. Okay, if the mom's blood pressure dropped because of epidural, they're going to try to get her blood pressure up. They may do a bolus, may give some meds even. Okay. We're going to increase IV fluids because if we increase blood volume, we can increase blood flow to the placenta. If they're on any medications, if they're on Pitocin, we stop it. If they have any, if they've been given vaginal medications to promote contractions, the only one of those that we can remove is going to be Cervidil because it's on a tape. The others are all going to be already absorbed. If we may give oxygen by non-rebreather, and we want to notify the provider, especially if those lates are severe, okay, or ongoing. So we want to try to get rid of them first. The very first thing is always going to be turn to the left side for lates. Now, let's look at the variable. The very first thing is change maternal position. It doesn't say which one, and that's because if it's a variable, it's because of cord compression usually. And so we want to move the mom around and try to get them off the cord, try to get the fetus off the cord. But everything else is just the same. Increase IV fluid, stop Pitocin, give oxygen, correct any known causes, contact the provider. Okay. So when we have a decel and we're trying to get it to recover, or we have recurrent ones that we want to go away, the first thing to do is going to be turn that person on their left side. Left side matters for lates because it maximizes blood return to the uterus. Which side doesn't matter for variables? Okay, so start with the left. Now, I want to talk about one other thing. I want to talk about what happens when a decel goes down and doesn't want to come back up. These can be stressful moments because sometimes they don't come back up. So these are extended or prolonged decels. It drops with this contraction. Contraction goes away, but the heart rate stays down almost till the next contraction starts. And then over here, we got another big one. It drops and it's staying down for 1, 2, 3, 4, 5, 6, 7, almost 8 minutes before full recovery. Drops down to an nadir of 60. Okay, stays. Now, in between these, the variability is not terrible, which would make me wonder if it's a cord issue, because if this is happening due to a placental issue, we're going to have less variability. But then we've got another one, and it's not even recovered by the end of this strip. This is a prolonged decel. They may begin as either a late or a variable decel. It's a decrease of at least 15 beats per minute below baseline, lasting at least 2 minutes, but less than 10 minutes. The interventions, we want to change the maternal position again. I would start by having them turn on their left side. If it doesn't come up, turn on their right side. This is when you're going to see us flipping that patient like a pancake. We turn them back and forth, trying to get the heart rate up. We want to increase their IV fluids. If they're on Pitocin, we stop it. We got to stop any contractions going on or try to decrease them while this is happening. Correct any things that we know of. Contact the provider. And if it's not coming up, we're also preparing for an emergent delivery. Now, if this recovers, then the provider makes the call whether to go ahead and deliver now or continue monitoring and see if it happens again. So these are the ones, and I've seen patients do this a few times through labor, but like several hours apart, and you're just kind of waiting to see if it happens again. These are kind of stressful labors, but this is still not a guaranteed C-section. If it doesn't come up, if it's staying down here and it's not coming up, they're prepping for C-section, because I've seen them stay down, and then continue to go down and stop. So if it doesn't come up, you're prepping for C-section. When it recovers, then let's wait and see a little bit. It is better. This fetus is going to be acidotic after an 8-minute decel. The fetus tends to recover better from that acidosis if they can safely stay inside and let the mother deal with the byproducts of that recovery. So they tend to recover from the acidosis better if they can stay inside. But if they continue to have long 8-minute decels, they're not going to recover from the acidosis. They're just going to get worse and worse. So one of the reasons to let them stay inside for a bit is to give them a chance to recover if the fetal heart rate is reassuring. And this is tachycardic, which we would expect it to recover to tachycardic. The variability is minimal to moderate. I would say it's minimal here. We got a little accel here. I'm thinking it could recover, but now we have this other big decel. So if we're doing this very many times, they're not going to be able to tolerate labor to get to delivery. It may be that the cord is in a place that every time there's a good contraction, it gets compressed. They're not going to be able to get to delivery in that case. Okay, so we've talked about decels. In the next section, we're going to talk about classification of fetal heart rate tracings.